Thank you very much, everybody. It really is an honor to be part of this Dental XP meeting. It's not so much of an honor to be the first speaker after lunch, but I'll try to make sure we get past that. And it really is, this subject is a pet project of mine that's been developing and evolving over the years. I am in practice in Boca Raton, and I'm very pleased to be one of the local talent that is on the podium here along with Dr. Ordonez. And also, I'm sort of representing Nova Southeastern University, where I spend a lot of time. If you look at sort of my homes, my office is in Boca Raton on the left. I practice with two other periodontists, Sammy Svaz and Fred Norkin, on the left and right of me, respectively. And I also spend a day a week at Nova Southeastern University. And all of this is a great collaborative environment because we stimulate each other and we problem solve and we innovate and we apply knowledge and techniques and get insight as to what we're doing. Like all the speakers, we all have some corporate affiliations. I don't believe that any of these really color my impressions, the way I do things, or my decision making. And like the other speakers, specifically Dr. Picos, I don't alter my photos other than to enhance their projection ability. So when I was asked to do this presentation about three-dimensionally reconstructing patients, or the fully edentulous patient, the first thing I had to do was define what is a fully edentulous patient. And this is a patient that came to mind who is kind of typical of the patients that we see at least many times around here. We have a patient who's got his last tooth that's about to come out. He's basically in full dentures in the maxillary and mandibular arch. He's got a mile of bone resorption. He's got a load of freeway space, and he's really ideal for this. And if we look at either a cephalometric view or the cone beam view, we can see that he's got loads of bone, at least anteriorly, and the maxillary posterior is pneumatized a little bit. But we have a tremendous amount of inner arch space to work with. So this is one type of patient for us. On the other hand, here's another older patient who's also completely edentulous. But when we look at his case and we look through some clear dentures that are radiopaque to be used as a scanning appliance, you can see that when he's in full occlusion, this guy hasn't lost a millimeter of bone. He's had almost zero bone resorption. And if we look at his scans, both from the panoramic view or from the cross-sectional view, you can see that there really is very little inner arch space to work with here. So this is a somewhat different problem for us to solve, and we cannot apply all of our same techniques to one patient as we might apply to another. Or let's look at this patient, who's the classic description of posterior bite collapse. Now, she's not fully edentulous, but pretty soon she's going to be. So I chose to include these kinds of patients too, because she's got all of the dental disease that we deal with. The periapical lesions, periodontal disease, caries, bite collapse, and everything else. And you can see where her incisors wound up. They're sticking out of her lip. Or a patient like this. We also have younger patients that fall into this category too, where we also have tremendous dental disease, whether it's caries, periodontal disease, bite collapse, malocclusion, you name it. This is another edentulous patient, so we have this problem to solve as well. And then finally, if we look at her in a cross-sectional view, and unfortunately she wasn't in full occlusion when we took this scan, but you can see that her landmarks are completely off. Her vertical dimension, incisal edge position, and everything else is off for her. So we need to deal with these various kinds of patients, and here's another one who's got his vertical or his occlusal landmarks basically intact. His incisal edge position is okay, or it's close, but he's got all the dental disease too. So there are many different variations of the fully edentulous patient that we have. And I've sort of chosen to break these into two categories. One where the clinical crown length is is greater than the anatomical crown length. And these are the kinds of cases that we can talk about hybrid restoration. Mike Picos did a great job in setting me up this morning. And I'm going to sort of pick up a little bit on what he showed and offer some alternatives. But these are the cases where we have the inner arch space and the space for restorative materials in order to create the prosthetic base as well as the teeth. These cases really can't be done as a traditional crown and bridge case unless you start doing some vertical augmentation or orthognathic procedures, whatever, in order to move the alveolar housing more incisally. The alternative is the case where the clinical crown length is approximately equal to the anatomical crown length. And these cases require sort of a more traditional ceramimetal or PFM type approach than a hybrid type approach. And the alternative, if you want to put this patient into a hybrid, you have to remove an enormous amount of bone in order to create that interdental space. Now, with either case type, you certainly have some prosthetic work to do in terms of reestablishing vertical dimension, making sure you know where the incisal edge position is, and understanding how this patient is going to function once we do these cases. So, again, if we look at some of the patient factors that are involved here, the patient on the left side of this video clearly is different anatomically than the one on the right side, where we have a full alveolar housing versus virtually nothing left. We have to look at incisal edge position. In this patient, you can see how she's certainly overclosed, but her incisors are actually buried below her lower lip. And her proper incisal edge position probably belongs somewhere near her gingival margins. What's more, in this patient, she hasn't got a whole lot of alveolar height. And if we look at her in cross-section, there's a roughly 30 or 25 millimeters of space between the incisal edge and the floor of the nose. If you cut off 10 millimeters, which is roughly the length of the incisor, and then established another 15 millimeters of inner arch space for a hybrid, you'd be looking at the floor of the nose. This is not a patient that can have a hybrid restoration. So we have to have some prosthetic guidelines in order to diagnose these cases so we understand we're picking the right restoration for the right patient. Other factors include gingival display. And we know all about the low smile line, medium smile line, and high smile line. We don't often think of this in terms of what is the pontic design going to look like. Is there going to be enough space to develop an emergence profile or to put all the restorative materials underneath that incisor or that tooth in order to create a normal ridge form and maintain it in a cleansable fashion? This is not cleanable, and maintenance is going to be a problem for all our patients. We have to consider that up front. And typically the teeth and maybe a little bit of the gingival tissue are what support the lip. This idea that we have to stick plastic up underneath the nose in order to create lip support doesn't hold up very often. We also need to, again, recognize how much alveolar resorption has occurred. This is the case where if we're going to do a hybrid, we have to turn this patient into one of these two patients in order to treat them. And that really is potentially disfiguring, and it may be excessively aggressive in order to accomplish that. If we don't hide the seam of the restoration properly, we can be looking at the edge of the prosthesis and the lip at once, and that can be very unaesthetic. So again, these are considerations that need to go into this planning and restorative technique. Ollie Jensen just came out with a classification system for implant positioning and strategies for implant placement and the implications for prosthetic design that is to be released for the Journal of Prosthetic Dentistry. But this also helps categorize some of our patients and put them into the right boxes so we know what to do. We have talked a lot about this idea of immediate loading, and we've almost taken it for granted this morning that this is a reasonable and rational and predictable approach. And I was fortunate to be part of the ITI group about a year ago that looked at the available literature as it related to loading protocols to determine is there a literature base for immediate loading? And the answer is there definitely is. And we're going to hear from Dr. Gallucci tomorrow, who is our chairman of this group, but there's a lot of well-recognized faces and names in that group. This was published last month in IJOMI, and we came out with a series of recommendations and conclusions. And I'll briefly highlight them because I don't have abundance of time here. But bottom line is that we have to be very concerned about primary stability with immediate loading and the implant design, occlusal factors, patient habits, systemic health, et cetera, which are kind of common sense items. Treatment of edentulism with these kinds of cases is complex. Don't think for a second that they're simple, because they're not. These all involve very high-level type planning and surgical procedures, and even though we may get up here and show you how all you have to do is follow the sequence of events, there's a lot of places where they can go wrong. And I think the most important statement that came out of this group was that immediate, early, or conventional loading with one-piece fixed interim prosthesis have demonstrated high implant and prosthesis survival rates, and underline this, can be recommended for the mandible and maxilla. So there is no magic number of implants, there is no magic arch that you can treat, provided that you use rational design and appropriate analysis. These cases can all be done and can be recommended. That really is a huge statement. And finally, that there are certainly patient-centered benefits. There are reasons that patients should desire these types of cases because they do benefit from them as opposed to the more traditional approaches. And last but not least, again, there is no magic number to the size or distribution. So when we look at the various factors that go into why would an implant integrate, there's a number of different categories, and they happen to include patient's health, bone quality and quantity, implant stability, site preparation, sterility, surface texture and chemistry. But at the end of the day, loading is only a problem or a factor if it interferes with stability of the implant. So all of our strategies have been devised to make sure that the implants stay stable while they're still put into immediate function. So I want to talk about a system or a methodology that we use, which is a little bit like Mike Picos's, but it also has some differences to it. And we've adopted this for a variety of different reasons, and I want to illustrate that as I go through this patient. This is someone who traveled a long way to see us, and her son-in-law was a dentist, actually, but she knew that she was losing a few more of her maxillary teeth. She didn't like her gummy smile. She was a little bit collapsed and wanted a new full maxillary restoration. She had pneumatized posterior maxillary alveolar ridges, not a ton of bone to work with. And we went through a planning stage, and all these patients do have a cone beam scan. All these patients do have 3D analysis, although I don't always make the surgical guides for them. But this is the distribution and placement of the implants that were planned. 2 tilted implants in the posterior maxilla, and then 2 axial implants in the anterior maxilla. And what we then do is go through the process of figuring out where are her teeth supposed to be. This illustration or this model doesn't show the posing model, but you can imagine we retracted the anterior teeth and made them a little bit narrower, anticipated where the incisal edge position was going to be, and then that was part of the diagnostic process. We then have our laboratory make up 2 Omnivac shells of the wax up, and then we go to work. I do not typically make a denture, and we do not do the denture conversion process for a lot of different reasons. So then we go into the surgical procedure, and it's very similar to what you've already seen this morning, where we take out the teeth, flap the ridges. This shows half of the alveolectomy being done, and this was predetermined by knowing how much interdental space or inner arch space we needed. Also, we knew that this patient had a gummy smile, and we would have to actually remove a little extra bone in order to get the seam between the restoration and the tissue up underneath her lip. So we flattened the alveolar ridge and placed the implants. This is a different patient. If you're very astute, I didn't document every step in this patient. But you can see we're testing the torque of the implants because they need to be stable when they go in. 35 is safe. Less than that is not necessarily safe, but doesn't mean we don't use them. And then we place angled abutments and straighten out the distribution, the angulation, so that we can use a screw-retained restoration. And these abutments get torqued in, again, following the one abutment, one time philosophy. We then attach closed tray impression copings, and then take a bite. And this is a video of what that looks like. It's nothing special, but we're just a different patient. This lady did not just grow a mustache. Nothing special. This is using a PVS impression material. Let it set, take it out. This is done after the patient is sutured so that you don't get impression material under the flaps. And then we move on to the next step, because we're going to have this provisional made in a dental lab. Because I want the mess, I want the problems, I want the issues of having a provisional made in the technician's lab, because that's where his facilities are best, and that's where he's most comfortable. I like working in my office, technician likes working in his lab, restorative dentist likes working in his office. So we keep these areas somewhat separate in this method. And we take the first OmniVac shell now and put it in the mouth, and we can check that the patient's in the correct vertical dimension using extraoral landmarks, and you'll see that in this video in a second. And then what we're going to do is squirt some bite registration material underneath the OmniVac shell. Once that sets, then we'll put a bead of material on the occlusal surface so we get a good registration of the opposing arch. And if you look at this at a video, you can see we have upper and lower OmniVac shells. This is a patient that is undergoing a full mouth restoration or a full mouth 3D reconstruction. And we have OmniVac shells that are verified in the correct vertical dimension. We've verified his occlusion. And now all we're doing is pumping in a little bit of the bite registration material through perforations that are in the OmniVac shell. So we're going to let that set up, holding the patient in the correct vertical position. Here you see just checking that vertical. This is a little distorted, but it's really done for the camera work. And then once it sets, we're just going to put a bead of material so that there is a little greater precision. This patient was exhausted because we did both arches in one day, and we actually made provisionals 2 ways. So he was sort of resisting his centric relation, but you can still guide him into an appropriate position. And we can also verify where the midline should be. This also gives us an idea where the occlusal plane should be. And all of that is predetermined from the preliminary wax-up. It can also all be tried in the mouth in wax form or in bite rim form. And then once that sets, we take them out. So our commitment to our patients is that they leave with teeth. Nobody leaves our office toothless. And I've just told you that the dental lab is going to make up this provisional, which is not going to be delivered the day of surgery. It's going to be delivered a day or 2 or 3 later. So we need to make them a provisional that they can wear out the door. And this technique was really inspired by George Romanos. I don't know if he's here, but thank you, George. And what we do is we pick the one strongest implant, typically an anterior implant, and attach a titanium cylinder or a temporary cylinder to it, put protective caps on the other implants. Now we take the second OmniVac shell, which has been lubricated internally, fill it up with self-cure composite so that it traps the titanium cylinder in it. And then when we take it off, you can see it's also picked up the indentations of the healing abutments on the other implants. When we look at this in the video, you can see how this is done. So we're just seating these in the mouth, and on this patient there is a titanium cylinder about in the number 7 and the number 26 positions. And we're just getting them in the right position, holding them in place, and now just squirting in some of the self-cure composite material. One error we made during this video is there should be little perforations in the incisal edges. You'll see we come out with a lot of bubbles in the incisal edges, which probably doesn't bother the patient, but it bothered me, and it made for less than ideal photography. But you can see we're just gently squirting this in. This is a somewhat crude technique, without question. but it's effective, and patients really can walk out, they can smile, they can see something white in their mouth, and they believe that they got adequate teeth. Of course, the concern from everybody is, but it's only held in by one single implant. Well, if you think about how implants heal, we know that they are the most stable in the first week following placement. After that time, they start getting a little bit looser. So you can somewhat abuse an implant during that first week or so right after placement and still not worry about ruining the integration. I certainly wouldn't leave it like this for very long, but it can function overnight or over a weekend, depending on what the turnaround time might be for the lab. So here you see just breaking these out of the out of the OmniVac shells. We can clean up the incisal edges a little bit. We're not going to worry about hygiene. We're not going to worry about ridge lap design and everything else, because the lab is going to do that on the processed provisional. What we've got here is just something that's adequate for the patient to go home with. We also tell them not to eat anything of any great difficulty, and basically a liquid diet until they come back and get their processed provisionals. So at this point, you see we've just polished those up a little bit or trimmed them a little bit. Unfortunately, you see my bubbles on the incisal edges. His occlusion was off a little bit. We quickly equalize it so he's contacting on both sides, and then the patient goes home. And this is enough for a patient to look in the mirror and feel like they got something for all of their time spent in the chair. These provisionals can take as little as 5 or 10 minutes to fabricate. So he leaves like that. Our patient that traveled from Tampa, because there are apparently no good dentists or surgeons in Tampa from what we've heard this morning, this is how she went home. And she came back. These are her lip line aesthetics, and this is how she's going home that day. So we send the patient home, and we write a prescription to our lab. And I think there's a lot of advantages to doing this way, because we're going to have the patient go through this the lab go through this process, and we're going to control the contours. We can make these provisional restorations very thin so that they are more crown and bridge-like and less denture-like. And the lab gets the case, pours it up, attaches these impression copings, takes my bite registration, snaps it in place, and you got to love this, because of all the technology we're talking about here at this meeting, we're using rusty nails to hold our cast together. Nonetheless, it's very effective, because he can then attach temporary cylinders. Mike Peterson likes to make a welded frame on this, which is internal, so it's not external. Makes it very strong, very rigid, and then he basically buries that in wax and then acrylic so that this becomes the provisional restoration. And you can see the contours here are thin, they're strong, they almost always fit. In fact, I personally haven't had to cut one, but I'm sure that'll happen next week. And we place it in the patient's mouth, and there is going to be some occlusal adjustment that needs to be done. This procedure, this delivery procedure, can occur in the restorative dentist's office. So again, it separates us out into, most of us practice a referral model, so that restorative dentists can be delivering this case. And then, as you can see, we go through a process. We close the bite. She was a little open here. And this is how she leaves the office. And then she goes through the normal healing process, 3-month post-op. Ultimately, she had a zirconzon type final restoration done. And I don't think there's any compromise whatsoever in her results. And she did this from start to finish in 6 visits. And I don't think that there's any compromise whatsoever. These cases also, the same methodology can work for these cases where there's no interarch space. And I'm going to speed through this a little bit. This is using some guided surgery, but it's the same idea. We're replacing implants, again, through the predetermined planning, taking a bite registration, attaching a single temporary cylinder. This time we took his dentures and used those for his overnight provisionals and just attached a single coping. This is how he leaves the office, day 1. 2 days post-op, he comes back and we have processed provisionals to place. And these are accurate, they are strong, and they go on and they really hold up very well. So I suggest that you, in the front rows, put on your sunglasses. This is what we call bokeh white for a shade. It's pretty similar to Beverly Hills white. And this guy did fine. These implants all healed and there was no problem.
Fixed teeth are better than removable teeth.
Yes, yes. And that's not even something we've talked about, even what that, you know. And I was also, you know, I had removable partials. So it wasn't something I would, you know, was putting out of my mind completely. But this is night and day. Just thinking about that, these are my teeth.
That's great.
Yeah.
And today you feel great, you said.
I did. I feel great. I have no pain at all and very, very little swelling that I could tell. And yeah, it's amazing. It's amazing.
What would you tell friends, relatives, colleagues, someone else that was in your situation? And you also indicated that you sort of discovered a lot of people have this same kind of problem but don't talk about it.
Yeah, I'm going to be more open, I think, about what I've been through and the procedure. You know, if it's not obvious to people, I'm going to offer it because I realize that when, you know, for whatever reason, but certainly in my case, you know, age or dental care in the past got me to this point. I know I'm not alone. You know, so I think just by being open about it, I will highly recommend this procedure to anyone.
Okay, just to conclude, there's no question that we can do these cases predictably. Immediate loading protocols certainly are predictable as long as we follow all of the principles and steps that go along. There is no single treatment modality, no bridge design, no magic method that is correct for all of these patients. Tilted implants, guided surgery, CAD/CAM restorations, it changes the picture and it keeps improving our ability to treat these patients better and more cost effectively. We prefer this next day delivery model because it kind of takes the stress off everything. We can do a full mouth in about 4.5 hours or so. That's with the overnight provisionals. And then the delivery appointment is about an hour or an hour and a half the next day. And patients are comfortable and they don't mind that second step that goes in there. And with that, I'd really like to say thank you and appreciate the opportunity to talk to you.